All right, guys, we'll get started. And if people join along the way, then they can kind of catch up with where we are. This meeting is being recorded, so if you want to keep your screens, your cameras off, that's totally fine by me. But if you guys could still contribute via audio, that would be helpful. Okay. So I hope everyone's had a chance to go through and read the paper that we've been sharing for this week. If you have any questions along the way, just unmute yourself and ask away or pop it in the chat. If I'm sharing my screen, it's a bit more difficult for me to see the chat, so it's better if you guys can just unmute yourself and ask your question. Okay, so if I say anything that you don't understand or if you wanted to clarify something. Right, so I'll open up the paper that we should have been analyzing. And I'll share that. So this is actually a paper that one of our group members has written. I can't see that she's actually joined the session right now. Um, but if she does, it'll be helpful for her. So this is a systematic review and meta-analysis of randomized control trials. So I hope you guys have used the checklist that I shared for critiquing a systematic review and meta-analysis for randomized control trials. So we'll get started. The first section of the checklist deals with basic study design and to see if the way the study was designed is appropriate to answer the question that it's asking. So this study is looking at the efficacy and safety of remimazolam versus propofol in elderly patients undergoing gastrointestinal endoscopy. And we've got the introduction stuff that you guys should have all gone through. So, first question is, does the systematic review address a clearly formulated research question? Yes, no, or can't tell. So here we're looking at the PCOTS criteria. What do we think?
I would say yes here.
Yep.
I would
Yeah.
say yes too.
Yep. So, Mariam, for example, can you give us some of the PCOTS criteria that you found? What's our population that we're looking at?
So the population is basically the elderly patients undergoing GI endoscopy. And the intervention is going to be remimazolam. And the comparison will be propofol. And the outcomes will be efficacy and safety outcomes.
Yeah, perfect. So yeah, our we've got our it's where does it say it? Yeah, so we've got the eligibility criteria here. So the meta-analysis includes RCTs comparing remimazolam with propofol for sedation before GI endoscopy in elderly patients. So we've got elderly patients over 60 as our population. Our intervention is remimazolam. Our control is propofol. Our outcomes, they've got it here. We've got sedation success and procedure success. And our the setting that we're looking at, the S is GI endoscopy. We don't know if they're looking at GI endoscopy in hospital or in like an outpatient clinic setting. We don't know if this is kind of more urgent or completely elective. So that's just a little bit vague. So, if they wanted, they could have, and they might be looking at everything. So that's something you can also include in the eligibility criteria that, we're looking at GI and endoscopy in any setting, including hospital, inpatient, outpatient, urgent, elective, emergency, whatever. You can kind of be more clear about that. Um, the other thing is, what do we think of the outcome, sedation success and procedure success?
Yeah, that's one thing that I found is that well, it's like some of these outcomes seem like they could be a little bit vague unless later on they talk about specifically how they measured it. And for dichotomous outcomes, how they decided which was, a positive outcome, which one was a negative outcome. Um,
Yeah,
because
so
it seems like quite a few different ways of measuring a certain, like patient satisfaction, for example, can be measured by a whole bunch of different outcome measures.
mhm. So, and the thing with patient satisfaction is, yeah, all the studies I'm sure will have their own way of measuring patient satisfaction. Um, but you can kind of standardize the differences between each different type of measurement and still kind of use that. But I think with something like sedation success and procedure success, I couldn't see anywhere in the paper where they clarified exactly what they mean by this. Um, so, because propofol and remimazolam can both have successful sedation. So what does that mean? How do you compare the differences between those? And the same with the procedure success. So, that's just something to keep in mind because when you have vague outcomes, you get lots of heterogeneity because you're not focusing on a very specific thing that you're looking at. You're looking at quite broad, umbrella terms, so they can cover a lot of different types of data under there. So it's something to bear in mind. And then did the researchers search for appropriate study designs to answer the research question? So what kind of studies were they looking at and were they appropriate?
I mean, it was only RCTs, and they clearly say that they only wanted RCTs. I think that's that's good.
Yeah, I would agree. So it says they used RCTs. RCTs are the best to compare two different interventions with the outcome. So I think that would be appropriate. So I said yes for that one. So to start with, I think, is a basic study design valid for systematic review? Probably. So, they've got the right types of studies. They've spelled out their eligibility criteria. It could be a bit more specific, but it's pretty clear what they're looking at and what they're not looking at. So, I think it's then worth continuing with the checklist and, analyzing what's to come after that. So then we move on to section B of the checklist. Is the systematic review methodologically sound? So to begin with, were all the relevant primary research studies likely to have been identified looking at the search strategy? So here we look at, is the search strategy comprehensive and clearly reported? Did they include major bibliographic databases like Medline, PubMed, Embase, etc.? Did they use mesh terms as well as like specific keywords to look for their papers? Did they include non-English language studies? Did they do hand searching of reference lists? Did they look at unpublished data and consult experts? These are just some of the things that we kind of look at in this searching for primary studies. So, any thoughts here? Can we hear from some
Well,
people that we haven't
yeah, so they used they used Medline, Embase, and it seems like they did like terms didn't include like endoscopy, GI, which are I think like those mesh terms. Um, so I think they used like reliable um databases, what I'm trying to say.
Mhm. Yeah, I completely agree with that. So they've clearly used mesh terms and they've used keywords like they've mentioned. They've looked at, so let's look at the the databases they've looked at. So they've got Cochrane Register of Clinical of Control Trials. They've got Medline, they've got Embase, and they've got clinicaltrials.gov. So that's good. Medline and Embase are the big ones. And since they're looking at clinical trials, they've got some specific databases that they've also looked at. The other ones, I know people sometimes use Scopus, use Web of Science. Those are also good databases that you can extract data from. Uh, so that's just something to bear in mind. But I'm sure they've, got much of their data already from Embase and Medline. What do we
I
think of
couldn't
this?
tell. Oh,
Yeah.
sorry. I was just gonna say I couldn't tell if they used like I don't think they used any other studies with from a different language or different countries. So I think these are only English studies,
I think they mention it.
but I'm not sure.
I think they have mentioned that no language and
Yeah.
Oh,
Oh, okay.
restrictions were applied. But one thing that I was thinking about is that they do have mentioned like the mesh terms, but they haven't mentioned about the M tree or equivalent terms of M-base.
oh, I see what you mean. So like yeah, mesh terms are specifically for Medline, I think. And you're saying they haven't talked about what search they did in Embase. Is that correct?
Yeah, I'm talking about that.
Yeah, I agree. So I actually haven't ever done a search in Embase. It's very expensive and I don't have institutional access. So I don't know what the mesh equivalent for Embase looks like. I don't know if you guys have more experience than me, but I do understand that, this kind of method is different in Embase. So yeah, that's a very good point. They've included their Medline search, but they've not included their search for Embase. The other thing I would say is I'm not sure if it is comprehensive enough. So just on like a very technical note, I don't know how much you guys know about searching for terms in Medline or other kind of databases. But do you know about the use of an asterisk in like towards the end of a word? If you want like a word that, and so for example, if we say endoscope, but at the end of the P, instead of putting a Y, we put an asterisk there. That covers endoscopy, it covers endoscopies, it covers endoscopic. It covers variety of different endings if you put it after a certain letter. So I know they've got endoscopy and endoscopies in here, but there could be a paper that was titled, endoscopic procedures, which they've not covered in this at all. So I think, their search strategy could have, at least with this one small change, may have introduced a couple more studies that they could have looked at. So definitely, use that asterisk when you're doing your search strategies rather than I try and avoid using full words when I'm doing keyword searches, just as a general rule. I'll always try and use an asterisk where I can, so I can make sure that I don't miss anything that could be, awkwardly named. Let's put it that way. The other thing that's good to do, who is the best person to come up with search strategies for a research paper? Is it the researcher? Is it the PI, the primary investigator? Is it the lead researcher? Or is it someone else? Who would be the best person to consult to come up with search strategies?
I think you said previously that like
I
a
think it might be
librarian
primary
would.
investigator.
Sorry, Lucas, Mariam will come to you in just a second.
I think we'd spoken about earlier that actually like experienced librarians, like university librarians, can be quite helpful if they've got experience and like extra training in that sort of thing. They can help you create a really comprehensive search strategy.
Yep.
So that could be something to, if you've got access to, that could be something to consider maybe.
Absolutely. Mariam will come back to you. What were you saying?
I think the primary investigator might also be a better person.
Yeah, so the best practice. So, like Lucas was saying, hospital and university librarians, uh, in most places, will have extra training when it comes to coming up with search strategies for different databases. This is what I've been told. I've never used one, but this is what I've been told. They're the best resource to make use of when it comes to coming up with search strategies. Now, of course, the primary investigator, like Miriam says, needs to, or the lead researcher needs to be heavily involved with this process because the librarian can look up any number of different terms, but if it's not relevant to the paper, then it's not going to be very helpful. So the lead researcher who actually knows the project inside out and knows what they're trying to get at needs to work very closely with the librarian and come up with a good search strategy, a comprehensive search strategy, and that's going to give your paper a lot of kind of backing. The other thing is it's good to so they've set a search strategy kind of in the text in about 5 lines, but the better practice is to have it in a table, whether it's part of your supplementary material or in your appendix of the paper. But have a table where, you've got, this is the search we did in Embase, this is the search we did in Medline, etc. And each line of that table is a different search that you did. So, one might be this is a mesh term we looked at, this is how many studies it found. The next line is, these are the keywords we looked at related to the mesh terms, this is how many studies that found. And then the third will be, okay, this is the next one. Now we're looking at the interventions. These are the mesh terms. And then at the end, they kind of put all of that together, like the different lines they combine, and they'll say, okay, this is the final number of studies we had. Now that's really important because to have the best kind of research paper, you want to make it reproducible. You want to make it so that if anyone else is reading it and they have any kind of problems with your results, they can reproduce exactly what you did and see, do the exact same searches and see if they come up with any more papers or anything that you could have missed. Otherwise, you can risk, having like a follow-up editorial or like letter to an editor being like, oh, I read this paper with great interest, and actually this is the search that they performed. And when I performed the same search, I came up with 1,000 more articles than they did. So we think they might have missed something, that kind of thing. So definitely try and be as transparent as possible and include as much information as you can in your supplementary material. Now we touched on this. The good thing is they did not have any language restrictions. They also where did they say? Yeah, so they also looked at just struggling to find where they've mentioned it. But I think yeah, reference lists of included studies and similar systematic reviews were also screened to identify further pertinent studies. So that's a really good thing to do, is to hand search reference lists and see if there are any other studies that you might have missed. They could have gotten an expert opinion. Not everyone does. So, that's not something that I would hold against them. The other thing that I was unsure about is they've talked about sedation for this paper. I'm not sure in their search strategy how they made sure that they were looking at, you know, sedation only and not GA, because you can provide like a GA with propofol for endoscopic procedures, depending on, how badly it's needed. And again, like I said, we don't know if this was done only in electives as an outpatient, if this was done emergency. So, if it's an emergency, there is a higher possibility they might be using a GA. So, depends what they're looking at, but there's nothing in the search strategy or even in the eligibility criteria. Where is it? Yeah, because they say for sedation before GI, but they didn't say anything about excluding studies that used like a GA rather than sedation. So that's another thing to just keep in mind. Okay, so moving on to the next part. So I would say, what do we think? Do we think yes, no, or can't tell with were all relevant primary research studies likely to have been found by the search strategy? Do we think the search strategy was perfect, or do we think, it had lots of improvements that were needed, or do we think that, it was almost there, but a few other kind of improvements could have made it much more comprehensive?
I put down can't tell, just kind of in the middle there.
Yeah, I think I agree with you. I've put Contel as well. I think there's just a few things that we could,
Yeah, I think I can't tell as well.
yeah, yeah, agreed. Okay, so we'll move on to screening primary research studies from the search. That's the next part of this section. So here we're looking at did they have, and we kind of touched on some of this already, but did they have an appropriate eligibility or inclusion and exclusion criteria? Did the researchers design and implement a robust process to screen the primary studies, such as were two researchers working independently with a third independent researcher? To resolve any disagreements? And then was screening based on title and abstract of primary research studies that were found during the search? And did the researchers adhere to the eligibility criteria? So, um, the screening, how was the screening done, and do we think that was appropriate?
Yeah, they removed duplicates and used two people to do the screening of title and abstracts, which was good.
Mhm.
And it's not clear if they did the same for um, full text screening, but yeah.
Yeah. So firstly, yeah, they've got a clear inclusion and exclusion criteria. But like we said, it doesn't, we're not sure if, general anesthesia is also included or if it's just sedation. That could maybe, be clarified. Um, so just focusing on the title and abstract screening, they've got two independent. So they use Ryan. I've used Ryan before. It's a great program. Uh, they've got two independent authors performing the screening of title and abstracts to exclude all irrelevant articles, and they've provided who that was. Um, and they said any discrepancies over the selection of studies was selected by a third independent author. So that's best practice. That's exactly what you're supposed to do. So that's good. I put yes for that. I'm very happy with how they've, done their full text, their title and abstract screening. And then we go on to looking at the full text analysis, and did they adhere to the eligibility criteria, etc. So, like Lucas mentioned, here it says full text screening following our eligibility criteria was then performed on the remaining studies. Um, just a very small thing. They could have maybe added a couple more words to say, again, was it done by two independent authors and then resolved, and then follow it up with any discrepancies were resolved by a third author. That's completely fine. But it's just, it leaves. I'm sure they did it correctly, but it leaves it up to the imagination. If someone's being really critical, they could kind of question how this was undertaken. So it might just be worth making a note here that actually this was also done by two different people, if it was. And were these the same two people that did the title and abstract screening, or were these two completely different people? That's also something to keep in mind. Um, and the last thing in this section to keep in mind is the Cohen's kappa. Now, do you guys know what the Cohen's kappa is? So it's a statistic measure that they use to show how similar the two different raters who looked at, the full text or the title and abstract, how similar their judgment was. So how um, how much they were in agreement, basically. So if, one person included 10 different studies and the other person had said, you know, for the same 10 studies, they had excluded five of them, then, they'll have like an iterator, they'll have like a lower iterator, like agreement. So they'll have a lower Cohen's kappa. A high Cohen's kappa means that, with most of the articles, the two raters had independently made the same decision. So it's a good uh, measure to include, a good statistic to include in this data study selection section of your research. So do we say yes, no, can't tell for full text screening?
I put can't tell, because it could be that they got two different people to do it and they just didn't mention it, so I wasn't sure.
Yeah. Yeah, I think between can't tell or no, however much benefit of the doubt you want to give, I think I would agree with that. And then moving on to the next part, so summarizing the search and its outputs. So here we're looking at, did they have a Prisma flow diagram? And, did they explain exactly how many studies they started off with and then screened out and removed as duplicates, and how many they eventually included in the meta-analysis? And if they've excluded anything, did they say why it was excluded? So where are we? I think they'd mentioned the Prisma diagram somewhere.
I think because this is it's like a submission, right, or like a preprint or whatever, so I don't think the figures are in there. So no, I couldn't find the Prisma flowchart at least.
No, I agree, and yeah, I can't find a flowchart either. But they've mentioned it. They have got a Prisma flowchart illustrated in Figure 1. We don't have access to Figure 1, but they've obviously thought about this. So I kind of just based my thing on this, where they've written it out, which is good. So not sure if the Prisma is correct. It's a pretty simple, straightforward flowchart, so I'm sure they've done it correctly. But it's not up to me right now because I haven't seen it. The text explains the study selection process, so I think it's pretty good. I said, can't tell for this just because I haven't seen the Prisma flowchart, but once I've seen it, you look at all the different aspects if they've got that included. That's a yes, and then we can move on. Any questions so far? Anything anybody wants to clarify before we move on? Nope. Okay. So the next question we're looking at is, did the researchers assess the validity or methodological rigor of the primary research studies included in the systematic review? So here we're looking at the individual studies that they included and to see if they've made an assessment on how methodologically sound those individual studies are, because your meta-analysis is only going to be as good as the studies you've included in it. So did they look at a validated tool to assess the methodological rigor of the primary research studies? Was the tool appropriate to assess this type of study design? For example, using the Cochrane risk of bias tool specifically for RCTs. Did the researchers present the findings from their quality assessment and interpret them accurately? So what do we think about that?
I mean, they used the Cochrane risk of bias tool, which I think was the best choice here. Unfortunately, again, there's not that nice matrix that comes out of it, which is a shame, but they do mention broadly what the results of the risk of bias tool were.
Yeah, I agree with you. So it's clearly said that they've used the Cochrane risk of bias assessment, which is the best one to use for RCTs. And they've gone into a bit of detail explaining what it is, which is good. The risk of bias for each included study was assessed by two investigators, and any disagreement was settled by a senior investigator. So again, this is best practice. And then that way you can see, you've got two independent people making a judgment, and a third independent person looking at any disagreements and finalizing those.
And they have also reported their findings in supplementary figure 1, as they mentioned. However, we can't interpret whether they are accurate or not. Again, for the same reason, because I think we do not have access to supplementary figure 1.
Yeah, agreed, Mariam. I was going to say exactly the same thing. They have said that they've included the quality assessment in the supplementary figure 1, and they've kind of mentioned that, 5 studies were low, and 3 studies had some concerns of bias due to, these different domains. However, again, it would be nice to see the matrix eventually when it's published. Um, and again, it's better because I think when you use the risk of bias tool, it gives you the full matrix. Where they've on the left they've got each study, and then they've got on the top for the columns they've got the different domains, and it shows how each study scored in the different domains, and then it gives us like another overall summary. Now, some people just include the overall summary, some people include just the matrix, and some people include both. I think it's good to include both. But I think what's more important actually is to include that full matrix. So, and again, everything about research, we want it to be reproducible. And we want other people who are reading our paper, if they have any problems with it, we want them to see exactly what our thought process was, exactly how we interpreted different things. Because if they don't agree with our results, they can go through it and see where they disagree. And, if that disagreement you know, is something that's going to impact the outcome of the study, or that disagreement is something that, doesn't actually influence the overall results. Um, that kind of helps, especially experienced reviewers, to know what you've done and why you did it that way. Um, The other thing I noted here, and I know we'll go into detail about this a bit later on, but there was no mention about any subgroup analysis that was done by the risk of bias. So, we calculated the risk of bias here. We assessed that, but I can't see anywhere in the paper where it then draws that in to their analysis. So the studies that had some concerns of risk of bias, what how was that interpreted in terms of the results that we got, and to assess how that might have influenced the results. So that's something to keep in mind when we move on a little bit. Right. So the next part is, did the researchers extract and present the information from the individual primary studies appropriately and transparently?
I have a question here.
Yep.
I have a question here. I wanted to ask that, like, if you mentioned that risk of bias, we should include all the process and report everything. So we should just like, if we just include the traffic light plot, which is the, basically most people report that. So is that enough, or do we actually have to include the answers to all of the domain questions?
So honestly, in your supplementary material, I think you can include whatever you want. And depending on how transparent someone wants to be, they can, include every little thing that they filled out, every extraction table, all the versions of the extractions tables, etc. It depends, obviously journal to journal, but usually in the supplementary material, they give you more freedom to include whatever you want. Um, Generally speaking, from what I have seen, that traffic light plot, and then there's one that looks more like a sideways, bar chart almost, with like the lines, the green and the yellow and the red line. Those two are generally sufficient for people to see. So, but that traffic light, that matrix with lots of, the different squares, that I think is the most important to include because, yeah, you want to be reproducible. I get it. You want to give everyone that information, but just in that traffic light system, they're usually, if they have a problem, like, for example, if one of the authors of a study that you've included in your meta-analysis goes, oh, I don't know why they've said that my paper was a high risk of bias. Like I made sure that it wasn't. So they can go back and look at your matrix and see where you've scored them higher on the risk of bias. And they can see which domains. So the domains are pretty self-explanatory. Some of them are talking about how, if the study participants were blinded, if the investigators were blinded. So if anyone has an issue, they can find exactly where, they were scored differently. Or if anyone is trying to reproduce this meta-analysis later on, and they see that your risk of bias results and their risk of bias results are different for the same study, then they can look where the differences are in which domain, and they can go back and have a read. Now, if they feel like you've scored someone a high risk of bias, whereas you missed something in the paper, in that original paper that mentioned that, this mentioned the concerns that you had and actually uh, kind of addressed those, and you may have missed that, and that's why you scored them highly because you said, these practices weren't done, then that person can come back to you and say that actually, we think that you might want to amend X, Y, and Z in your paper, depending on, if it impacted your results or not. It can sometimes be minor errors. We know that these are subjective measurements. So there is a bit of variation from assessor to assessor, but it just depends on how much impact it has. But yeah, to go back to answer your question, I think, just that traffic light plot is usually sufficient.
Okay, thank you.
You're welcome. So yeah, the next part, so, was the extraction process robust for the data? Was there any guidance that the data extractors for the meta-analysis they had to follow to make sure that they were extracting things correctly? Was there a standardized form or a software program that extracted the data on their behalf, or, that you used to make sure that the data was complete and accurate? And did the researchers extract all the relevant data for the study characteristics? So what do we think about that data extraction?
I think they used Excel, which I think is not a bad choice. Obviously, there's some like more high-tech things that you can use to help you extract your data, but I can't say that I've ever used one. So, um, and they pre-piloted the Excel spreadsheet, which is also, I think, a good thing to do. Um, I think overall it was okay.
Yep, I agree with you. So the data was entered into a pre-piloted Excel spreadsheet, which I assume means that, the outcomes were that they wanted to look at were already there before they started analyzing the papers. So that's a very good thing to do. Yeah, I've never used any software to extract data for me, so I can't comment on that. Apparently, it is possible. I don't know what software to use and how that makes its assessments, but there are apparently things out there that you can use. Um, it doesn't, I mean, the only other thing I kind of questioned was it doesn't make any mention of, for example, who was part of the data extraction process. Like how sometimes they include who did the screening and who did the conflict, like the resolution of, any conflicts. It can be useful to include who did the data extraction and who then overlooked, you was as someone who checked it to make sure, because you can have, five different people if you've got like 30 studies to collect data from, and you have five different people working on it. There, because all studies are not identical in their measurements of outcomes, there is some interpretation to be had, to be done. So if any of you have done meta-analysis before, you'll know how many times you have to go over the data extraction spreadsheet, because some people have interpreted the question a little differently, so they've collected a different measure of data. So it's helpful to know that actually, these are the people that did it, and this is the person that oversaw it, and made sure that, everyone was on the same page when it came to what's relevant and what's not. But I think, otherwise I said yes to this. I think it's done pretty by the book. So next is presentation of data. So did the researchers present the key characteristics of the individual primary studies in a table? And did the researchers present the results of the primary studies in a forest plot, or combination of table and forest plot, including effect sizes, confidence intervals, and p-values?
I mean, there is a table for the characteristics of the included studies, which is good. And broadly speaking, the results are ordered in a pretty clear way. The forest plots aren't there. I wonder if that's also because it's like a submission, and not a finally published paper, but they're pretty clear in like the numbers that they put in there. For each result, they put, the number of studies that reported, the number of patients that were included, how many in each group, and then, the outcome measure, confidence interval, p-value, and then also the I-squared statistic. So
Yeah,
that's
so
pretty complete.
agreed. Yeah. So they've got a table for the study characteristics. That's good. Um, I wonder if they're, in the supplementary material, if they have like an overall data extraction sheet with all the supplementary outcomes, sorry, all the secondary outcomes. Because here, yeah, you've got the regimen, you've got these like the patient characteristics, but there will be a bigger table with all the primary and secondary outcomes. That can be something that's useful to include in the supplementary material, because again, if someone were to repeat that meta-analysis and they get different results to you, they can go back and look at your data extraction table and compare it with their own data extraction table. You may have found information that, in by digging a bit further, that the new people might not have, so they can see where your numbers came from. Or you might have missed something or misinterpreted something, which, the new group might be looking at and think, okay, this probably was not correct. So, we need to make those changes in ours, or we can, message or email these guys and tell them that actually this was done incorrectly. So it's okay. From what I've seen, it's okay for people to make mistakes when it comes to like small mistakes. Obviously, make sure that you're doing the best of your ability. But, if you aren't sharing your data extraction tables and stuff because you're worried someone might find a mistake. From what I've seen, there are some pretty good journals where people have done meta-analysis and systematic reviews, and they've got, some errors in there, which I thought were, quite significant errors, but obviously, like the journal didn't think so. So people have, messaged back to the editor saying, there was this and this mistake that, we think might be relevant. And the journal hasn't pulled the paper, they've just added an addendum afterwards. So, you've still got that, and it doesn't really have any major impact. So try and be as transparent as possible, but obviously try and do things to the best of your ability. And yeah, Lucas agreed. We haven't been able to see the forest plots in this. I'm sure they've got forest plots, but we can't assess that. Um, But yeah, so I've said yes or can't tell in this one just because we haven't seen the forest plots, but they've got all the information written within the text, so we can still make an assessment on the results. Right, so that part was all looking at the methodology and the data extraction. Now we're looking at the actual results of the research. Any questions so far? Hopefully this part will be shorter. I think most of the thinking goes into the methodology, so we probably should be another kind of 15 minutes if people are okay for time. So are the results of the systematic review trustworthy? So did the researchers analyze the pooled results of the individual primary studies appropriately? So this includes, undertaking a power calculation and a sample size estimation during the planning stages. Not everyone does that, but it is good practice to do. Um, did the number of participants whose outcomes were entered into the analysis meet the power calculation? So was the meta-analysis sufficiently powered? Did the researchers use appropriate effect measures? Did they provide confidence interval ranges and p-values? Did they have the statistical heterogeneity specified? So using the I-squared statistic, for example. Did they use a random effects model or a fixed effects model? Did they do a sensitivity analysis or subgroup analysis and meta-regression? And did they investigate small study effect and potential for publication bias using a forest plot or Egger's test? So quite a few things to look at in here. We'll start off with, I mean, you guys must have made notes on this, so just fire away. Give me any thoughts to address any of those things that we talked about.
So what I noted that is I can't see any funnel plots, and I also can't see any other bias test like Egger's test. And next is that there is also no subgroup analysis based on any effector, whether that is heterogeneity or not. And they have reported the heterogeneity values using the I-square statistic, and the heterogeneity in the I-square statistic is high in some cases. You can see 82% and 69%, but there is no like meta-regression or any other analysis done to solve that problem. And in their the data synthesis statement, they have not made it very clear about their methods, like a bit like about the subgroup and all that. I think they haven't done that, any of the subgroup analysis. So they've just done the basic analysis, random flex model.
Mm-hmm. Yep. So, yeah, I agree with that. There's been no subgroup analysis or meta-aggression done, and like you said, yes, we've got some moderate heterogeneity in the results here. We've got this is pretty low, so that's good. We've got quite high heterogeneity here. Same over here. So this one's low, so that's fine. But there are places where, the heterogeneity is quite high. Um, and generally, when the heterogeneity is high, you want to do a sensitivity analysis, to see, which studies are having the most influence on the results, and secondly, your subgroup analysis or meta regression will may give you pointers as to what's causing this heterogeneity. Okay. Uh, so that's it's the next step in meta-analysis. I don't know how many people know how to do that, and how many people actually do that with their meta-analyses, but it's if you want to have like a good quality end product, then the more in depth you go into finding answers. And again, the best thing to do is to have your subgroups pre-specified before you look at the data. But even if you weren't able to do that and you weren't expecting such high heterogeneity, and then once you ran your meta-analysis, you found afterwards that actually there's a lot of different, variables here that could have influenced the outcome. So let's look at what subgroups we want to analyze. So you can do a post hoc subgroup analysis, um, and it just makes it a little bit less kind of rigorous. But you, as long as you address that in your limitations and you say, listen, we weren't expecting it to have such high heterogeneity, so it was only after we did this we specified our subgroups and looked into it further, because the subgroups are only there to generate further hypothesis later on in life, because you're asking questions now with subgroups. You're like, maybe this subgroup is what's causing the results to be so heterogeneous. But maybe this is something else that we can research and see if that's what's affecting the results overall. So subgroups are only meant to be hypothesis generating, I believe. They're not supposed to be used to answer any questions as such, because you're not doing a full, rigorous analysis with those. So it is very good to have a subgroup analysis, like Mariam said. So we've got a power calculation wasn't done, but I'm not sure about how relevant that would be here. What effect measures have they used? So we've got mean difference and we've got risk ratio, a relative risk here. Um, so I think that's pretty good for effect ratios. The only question I had is, so procedure time, mean difference is fine because, time is, everyone will measure time in the same way. Um, but there was something where, yeah, for example, endoscopist satisfaction. Um, Mean difference is good to use when all the studies are measuring things in the same way, because you can compare the difference between the studies. But with things that, satisfaction rates, or, pain, like review about, patients' opinions about their pain, everyone measures that differently. Now, unless there is um, like a universally agreed uh, scoring system to use for endoscopist satisfaction, then they're likely that everyone's going to be measuring that separately. And you can still use the results of studies if they've measured things differently, but then you got to use a standardized mean difference. And what that does is it looks at it looks at each study individually and sees, what's the relative difference in their kind of mean difference, but it gives you an overall standardized value that can be compared across different studies that use different scoring systems. Does that make any sense? That might be a bit confusing.
Yeah, that makes good sense.
Yeah, no, it makes sense.
Thank you.
I wanted to kind of piggyback off of what you're saying, Faiza, if that's okay. And yeah, I'm agreeing with you. And I think the one issue perhaps here is that they were never really clear about how each outcome was measured necessarily, right? At least in my mind, and perhaps I missed that part in the paper that mentioned that. But uh, uh, it would be interesting to know if every single study counted, even for something as simple as bradycardia, like what the cutoff was to count a patient as having had bradycardia, right? Did they count, 50 beats per minute? Did they count 45 beats per minute? Did they count 55 beats per minute? And other things like endoscopic satisfaction is how did they count? How did they count that? What questionnaires did they use? Did all 8 studies use the same exact questionnaire for these things? Because that would also help us put a bit of weight behind the results to say, okay, well, the thing that we've compared by virtue of doing a meta-analysis is we've compared these outcomes. If these outcomes were actually comparable in the first place.
Yeah, I completely agree. I couldn't have said it better myself. Um, that's why I think we need to be so specific when it comes to our outcomes. And that's another reason why I think it's useful to have your data extraction sheet in your supplementary material because people can go and see, what was the range in heart rates for bradycardia, what was the range in scores for each study for the endoscopist satisfaction. And it all comes down to being very clear on what you did, how you did it. But yeah, I think even without that data extraction, it's important in your text, when you're talking about where was it? In the outcomes here, the primary outcome was sedation success measured as blah, 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 and procedure success, which was measured as blah, blah, blah. Um, Injection site pain, I think that's pretty straightforward. I don't know if this was how much pain they had, or if this was did they have pain or did they not have pain? Because if it's very binary and they either did or didn't have any injection site pain, that's pretty straightforward. Or if they are talking about, relative to each patient, how much pain they experience at the injection site with, the different regimes, then you need to mention how that was measured and how you were able to compare between different studies. Hypotension, again, what counts as hypotension? Because hypotension in, severely comorbid patient might be different because they might be more symptomatic with a higher blood pressure than a patient who had hypotension but without any symptoms. So it's all relative to your patient. So what was the cutoff value that they used in this paper? Procedure time, that's pretty straightforward. Onset time is straightforward. Time to fully alert, again, what counts as fully alert? In some papers, post anesthesia, fully alert is talking, eating, being able to recall, you know, things in their past, for example. Whereas for someone else, the fully alert is, extubated, breathing for themselves, eyes open, right? So do you see how there's a difference there? Just because you have your eyes open, you're breathing for yourself, you might not be fully oriented yet, and it might take you another half an hour, especially in the elderly. The time to fully alert can be so vastly different. So again, what did they use to measure how fully alert someone was? Time to discharge. I mean, that's pretty straightforward. Patient satisfaction, again, how do you measure patient satisfaction? Endoscopy satisfaction, how did you measure that? Vasopressor needed. Um, I mean, that's straightforward, but then again, for different studies, different hospitals, different practitioners, they'll use vasopressors at a different threshold. Postoperative nausea and vomiting, again, is that something that we just looked at binary presence or absence of, or severity? Prolonged sedation success, that's pretty vague as well. What are you looking at as a prolonged sedation success? Bradycardia, hypoxemia, again, numbers. Hypoxemia for a 60-year-old with COPD might have a different value to hypoxemia of a healthy 60-year-old who goes running every day. Respiratory depression and adverse events. So yeah, agreed. A little bit more information on those outcomes would have been helpful, and that might even reduce your heterogeneity if you're looking at very specific parameters. Then you're looking at the same parameters across different papers. Whereas if you just say if the paper said there was hypotension, I'm going to say it's hypotension, then you can have a lot of heterogeneity because different people measure hypotension or bradycardia using different thresholds. Anything you want to add to that?
No, and then I was just going to agree with Mariam, where they've got their results and they found that there's significant heterogeneity in certain of the some of the outcomes, but there's no like trying to figure out where the heterogeneities come from, how to sort of minimize it, and what may have contributed to it, which I feel is like a missed opportunity. Um, yeah.
Yeah, and whether you have significant results or not, as soon as you see high heterogeneity, it's very quick. And I think I'm not sure about RevMan. I'm more familiar with RStudio, but in RStudio, it's just one more line to add. When you're looking at like subgroup analysis, so it doesn't take too much extra work. I know you'll have to adjust your extraction table a little, but it's not a huge amount of work, especially, for example, if you've done the risk of bias analysis, you've already got that column in your extraction table. You just include that in a subgroup analysis and see if that affects you or reduces your heterogeneity. But otherwise, I mean, they've got their effect measure. They've got the 95% confidence interval for each, which is great. They've also got the p-value for each statistic, which is great. Uh, and I think somewhere, I can't find it right now, but somewhere they said they've used random effects model, which, if you guys are aware, is the one to use for data that has, or you suspect will have high heterogeneity, which in medicine seems to be the case because of how much biological variability there is. So it's good practice to use the random effects model, and that's what they've done. Um, And Mariam, you mentioned funnel plots and Egger's test. Is that correct?
Yes, I did mention that as well.
Yeah. So just going back to that, there is some debate about when to use funnel plots and Egger's test. For Egger's, I know that you aren't able
Yeah, I
to.
think you were talking about the minimum amount of studies,
Yeah.
because I think it should be 10 for agarose,
Yeah.
because most people take like the minimum studies should be 10 for agarose. But even if you are not using agarose due to that reason, you should define that you should like write it down when you're writing down the data analysis statement in your method.
Yeah.
I mean, that should be a part of like your protocol. When you're writing the protocol, you don't actually know how many studies you're going to have. So there, it should mention that you're going to do the agarose test. And if you don't do the agarose test because the studies are less, then you ought to mention that in the discussion, maybe. So that part is, I think, miss, because even if we don't do the agarose test, we should mention that in our like protocol for analysis.
Perfect. Mariam, you've said it beautifully. That's exactly it. And I know that they've mentioned that they've um, published a protocol for this already, and it's registered with Prospero. Again, we don't have a Prospero ID. You should include a Prospero ID. So, people who look at this can go back and find your protocol and compare that, if you've done anything differently to your protocol. But yeah, usually you will in your protocol mention that, we are going to do a funnel plot and an Eggers test if we have enough studies. So yeah, the minimum is 10. I think you can still make a funnel plot without, like, even if it's less than 10, to just get a bit of an idea. So you can still include it. However, for an Eggers, you do need 10 studies minimum. But like Mariam said, it's a very simple, straightforward line to include to say, we couldn't run in Eggers because there was less than 10 studies. At least that way people know that you have done everything you can to try and be as robust as possible, but there were some things beyond your control why you didn't do further analysis. And, not having enough studies uh, can be one of the reasons. So then we can skip over the next part. No subgroup analysis was done. Meta-regression wasn't done. So we're going to question 7. Did the researchers report any limitations? And I think this is probably the last part. So we're almost done. I hope you guys are hanging in. So we're now looking at the limitations. Also, just a very
Okay, one more thing that I want to add here is that in their outcomes, they haven't specified what was the time for follow-up of these outcomes. Like, were they assessed at 10 hours after the sedation? Were they assessed at, for even like patient satisfaction and the endoscopy satisfaction and all of these things? I think and for especially for the adverse effects, it's important to tell at what time, what was the time for follow-up, and they haven't mentioned that, and maybe that because of different time of follow-up of these outcomes, that could also possibly like introduce heterogeneity into this.
Absolutely.
Um,
Absolutely, Mariam, you're right on the mark here. So I did have that as part of my PCOTs. In T, I had a little like question mark to say, how much time was there to follow up with these patients? But I forgot to mention that. So thank you, Mariam, for bringing us back to that. It's a very good point to make. At what point in the patient's journey were these different parameters measured? Again, that if different studies measured it at different points, that will make your overall results more heterogeneous. Um, right. So just a side note here. Correct me if I'm wrong. All my life, I've been told that for p values, the p needs to be a lowercase p. Um, if that's not the case, then please correct me. I'm open to having my, changing my mind. But um, I think the best practice is to have a lowercase p. So, that could,
yeah, it is like the lowercase p. I think that is the real p is the lowercase p.
yeah. Yeah, because I think a big P means something else in statistics. I'm not sure what, but I think it had a different meaning. But I think it's a lowercase p, so that's just something very quick to change. I don't know if journals care or if they're not fussed, but it's just something that stood out to me. Right, so this is the part we're now looking at with the limitations. Um, so the questions we're asking ourselves is, whether the meta-analysis was sufficiently powered. Again, we didn't look at the power, so we're not commenting on that. Did the researchers consider the appropriateness of the effect measures and reflect on the precision of the effect estimates, i.e., the confidence interval? And did they comment on that? Um, if relevant, did the researchers note whether the confidence interval range included the line of no effect? So did they address the fact that actually some of these, confidence intervals and p-values were not significant? If the results were statistically significant, um, did the researchers discuss whether the results would be important or meaningful for the outcomes that they were researching? And did they comment on whether any primary studies could have been missed? Did they mention any systematic biases that could have influenced their outcomes, or, you know, comment on the risk of bias or the quality assessment of each studies? Um, did they mention any potential sources of confounding? Did they talk about any impact from the level of heterogeneity and any reasons for any heterogeneity or publication bias? So lots of things here to look at. What did we have any, we don't have to go in order, but did we have any kind of comments on the limitations?
I mean, I think like to start off, I think they've made some valid points about some of the issues with the included studies. Um, the fact that some of the RCTs were open label, the fact that they're all conducted in China, which very validly would put the generalizability of the results into question. Um, and the fact that each study used different dosage regimens. So I think that's a valid thing to do, but I don't think they reflected on the limitations of their own. Like they reflected on the limitations of the studies they included, but not necessarily the limitations of their own study. Um, like the heterogeneity that we'd found, their search strategy, and risk of bias, and etc.
Yeah. So like you said, yeah, they've got, some good characteristics here that they think could affect characteristics of the primary studies that they think could be influencing the results, and the generalizability. And then differences in research design, dose regimens, levels of sedation, and varying sample sizes are likely to confound the results. So they've got some confounding factors in there. They've mentioned the fact that all of the studies were from China, and they've addressed some of the potential differences between the studies. However, exactly like you said, Lucas, they haven't addressed their own limitations. So, for example, some of the significant outcomes. So, in the results section and in the discussion, they've mentioned, onset time, injection site pain, hypotension, bradycardia, hypoxia, etc. These were significant outcomes. There were significant differences. However, if you look at, for example, if you look at where's onset time, right? We've got the analysis was significant and revealing the superiority of propofol in comparison to remimazolam. Yes, you've got a significant p-value here, but look at the heterogeneity there, right? So that's pretty significant as well. So there needs to be something to address that, because that's the thing with meta-analysis. You can put lots of papers together and find significant results or insignificant results, but you look at the heterogeneity and you see, if the different studies were in agreement or they all disagreed with each other, but just that mashup of different numbers gave you a significant value. So there needs whether it's in the limitations or in the discussion, there needs to be some kind of reference to the fact that at least a line to say proceed with caution, because someone who's less experienced with meta-analysis might come across this paper and say, oh, I don't know what an I-squared statistic is, but the p-value is super significant, so that means propofol must be better in onset time. But actually, you have to be like, listen, you need to proceed with caution and treat this, take this with a grain of salt, because this is pretty different between the different studies. So that's just the responsible thing to do. With lots of different outcomes, that was a kind of similar finding. There was moderate to high heterogeneity between between the papers in different outcomes that had significant p-values. You could also mention, how, that your search strategy could be a little bit more comprehensive. And you can also, I think, like Mariam had said earlier, you can mention that you could have done a sensitivity or a subgroup analysis to address some of those high levels of heterogeneity. So what did we say? Did we say yes, no, or can't tell when it comes to, were most, if not all, the relevant limitations discussed?
I put no or can't tell.
I think I'd put no.
Yeah, I think no to can't tell is appropriate. I put no, just because I think there's you know quite a few things. I mean, no paper is perfect, and then we kind of all have to agree that no one does perfect research. But if you only point out the limitations of the studies you analyzed, but don't reflect on your own paper to point out any, because everyone has, methodological problems, no matter how big or small. But you have to be critical of your own work. And some of the papers that we've seen that didn't have great results, but their limitations, or did have great results, but actually their limitations were very critical of themselves, and kind of spoke to the audience and said, you need to interpret this with caution because of X, Y, and Z reasons. Then they have been higher quality, because you can see that people have tried to think very critically about their own work to try and make it better. So yeah, I think that we could have included a lot more detail in that. We can skip over the next few because there's no limitations for subgroup analysis or meta-regression. Just the last part here is, would the benefits of the intervention outweigh any potential disadvantages or harms caused when trying to implement this, if you act on the results? So any potential benefits or disadvantages or harms associated with the intervention, any benefits of intervention against the disadvantage of, the harms, and the overall balance between them. And then any potential demand for resources. So like, you got to think about cost, workforce, time, skills, training needs, if you're trying to change the what's already established into a new regime. So what do we think about that? Do we have any information on harms or challenges when it comes to um, implementing the intervention over the control? So from what I can tell, that there were some benefits discussed, but no mention of challenges. So the resources or the cost or the training in terms of, because propofol is a pretty well-established drug, across the world. And sedation with propofol is very straightforward. But if you are using something like remimazolam, which is different, to even using midazolam, for example, which I know a lot of people use for sedation in endoscopy, using remimazolam, does that come with increased cost? Is it a more expensive drug? Does it have different pharmacodynamics and pharmacokinetics that people will have to relearn before they implement it as the kind of standard treatment? Um, does it does it have supply issues? I know propofol has a huge supply because the demand's been so high across the world. But what about remimazolam? Does it have a short supply? Um, so, and if it's only been used, if all the studies are from China, it makes me wonder, is it being used so widely in other places? So I've put no to can't tell for this one, because we don't actually know what are the challenges of implementing remimazolam over propofol. So it says, the checklist says that if you have answered no, so for example, for question 7 for the limitations, we said no. It might be that, they didn't discuss the limitations of the systematic review meta-analysis as fully as possible. So it may, you want to interpret the results with caution. Don't just jump into implementing everything the study says into your practice. The last part of this is to talk about, whether this is relevant to your local system and to your local population. Again, I don't know how many of you work with elderly patients in GI in China, but if that's not you, then, not sure how relevant this would be to your local population. It's very subjective, this part of the checklist, and it's to everyone's specific needs. But it does open doors for further research in the West, for example, or countries outside of China. They might look at this and say, oh, this is actually really interesting. Let's perform our own study and see, what results we get. And again, the follow-up from that for question 10 is, will the implementation of the results represent greater value for your service users or your population? Again, very subjective. We don't have any information on resources or cost provided, so it's difficult to assess if that's going to be something that's easily done at your workplace. So what's our overall conclusion? Is it appropriate for this study to, like, would we take results from the study and implement changes in our own practice? Or, would we, is there things that it needs to improve on before we think that, it's good enough for kind of changing guidelines, etc.? What's the overall impression?
I think there are a lot of things that could be improved before it can be used for any decision making.
Anyone else? No? Yeah, so I've said, there's definitely some very good points, good insights and good data here. But because of the low generalizability, the moderate to high heterogeneity, with some of the significant results that you have, there's moderate to high heterogeneity. And without having a subgroup analysis to assess why the heterogeneity is so high, it's difficult to implement the results of this into like an overall, your overall practice. So I don't know if this paper has already been submitted or if, it's still being worked on, but if it is being worked on, there are things that can be done, even like post hoc, it can be done, but you would just need to mention that, this stuff is deviating from the original protocol. This was done post hoc just to um, investigate what other things might be impacting the results, but just more not to answer questions, but to come up with further questions for further research later on. But obviously, if it's already been submitted, then it's really in the hands of the editor and the reviewer to see if it matches their criteria for what they want to publish or not. But there's definitely some good insights, and we can't ignore that. But there is more work to be done. Um, and that brings us to an end. Thank you all for attending. I really, really appreciate, especially Mariam and Lucas, you guys have been so proactive in today's session, and you've shared a lot of your own analysis, and it's clear that both of you have gone through this paper in a lot of detail. It's very helpful for anyone who's watching this video or uh, has attended to see what kind of things we look at to make sure a paper is as high quality as it can be before it's published. Um, any questions from you guys before we close? Or any final?
No, nothing from me. Thank you for organizing this session. Very helpful. I think it was good to be able to review a paper um, that was kind of written by one of us, like one of the main group, because it means that we can actually learn things from each other and stuff. So that was quite helpful.
Yeah, thank you for that, Lucas. Actually, and I agree, we look at so many published papers, but we don't see the process they've gone through before they get to that point. So it's, and there are lots of published papers out there that still have, minor to major errors that, we can analyze, depending on the quality of it. But to see a paper, before it has been printed, when it's still in the phases where it's being worked on or just been submitted, is quite helpful to pick up on things that could be improved. All right, so we'll end the session here. Thank you all once again for your attendance. Um, I will try and share this recording with you guys once I figure out how to do that. But if there's nothing else, then I will close now.
Thank you.
All right, thank you guys.
Thank you.